Hi everyone. Today we're going to talk about the different subtypes of glomerulonephritis or GN that you're most likely to encounter either on USMLE Step 1 or Step 2. So I do want to just instantly preface this. This is like my attempt at like the most high yield stuff. So this is not going to be all of the information of GN. Especially, I'm not going to be talking about immunofluorescence patterns because it's fairly low yield overall. They will occasionally give you findings for immunofluorescence or electron microscopy. So if you want to be completely thorough on GN, I would highly recommend reviewing those findings, but only if you have time. This is really the most high yield stuff. GN as a whole is not a super high yield topic overall for step two. So this is just the fundamentals for each of those subtypes. So just as a review, GN as a whole will generally present with either AKI or proteinuria or hematuria. And it may or may not also have leukorrhea, which is white blood cells in the urine. And they also often have findings on your microscopy, so either red blood cell casts or white blood cell casts, so on and so forth. So once you correctly identify a patient has glomerulonephritis, let's make sure you'll be able to comfortably distinguish between the different subtypes. So on this table right here, broke it down to GN subtypes, pathophysio, presentation, some associations, and treatment. So let's start with IgA nephropathy or IgAN because this is the most common glomerular nephritis you're going to see in the entire adult population. It's primarily driven by autoreactive IgA immune complexes that attack the glomeruli, and that is going to be causing hematuria. The vast majority of questions you're going to see for IgAN, the primary presentation will be hematuria, whether it's microscopic and the patient might not even be fully aware of the symptoms, and you just pick it up on UA, or it's macroscopic, it's gross hematuria, and that's what causes their presentation to begin with. IgA nephropathy often follows a recent infection, particularly respiratory or GI infection. That's because there's a high amount of IgA antibodies found in these mucosal surfaces. And some labs that you'll see are red blood cells or red blood cell casts in the urine. In the serum, C3 and C4 is usually normal. So that's an important thing because some of these GN subtypes that we're going to be talking about later, they have decreased complement levels, but IgA nephropathy, that should be normal. So some associations, you might see IgAN with IgA vasculitis or Henoch-Schönlein purpura. So if you can recall, IgA vasculitis will classically present, the classic triad for that is abdominal pain, arthralgias, and palpable purpura on the legs or buttocks. So if you have a patient with those symptoms, with abdominal pain, palpable purpura, arthralgias, and hematuria, and we're asked what the cause of the hematuria is, what do we say? IgA in the glomeruli. So just keep in mind, IgA vasculitis doesn't need to present with IgAN, and vice versa. IgAN does not need to present with vasculitis. It's just a potential association you might see. And so for the next one is post-strep GN or PSGN. This is a type 3 hypersensitivity reaction, which means that you have these immune complexes circulating in the serum, usually consisting of IgG, IgM, and C3 that deposit in the glomeruli and thus cause inflammation and damage. This is also going to follow a recent infection, but it's specifically going to be a pharyngitis or skin infection. In other words, strep throat or impetigo. And PSGN usually develops within a few weeks. It's usually not immediately after the infection. And once it does develop, it most commonly presents with a hematuria, often described as like tea-colored or cola soda yellow colored urine, and or facial swelling. So you might have some mild periorbital edema or very mild pedal edema because keep in mind PSGN is a nephritic syndrome. So while nephrotic syndrome is more classically associated with pedal edema, nephritic syndrome, if there is pedal edema, it's very mild. For labs, you will see red blood cells and red blood cell casts in the urine, and you will also see a decreased C3 levels. C4 might be slightly decreased, but it's usually normal. It's mostly about that C3. Um, and no notable associations, but for treatment, it's going to be mostly supportive because this resolves spontaneously. Most of these GNs you'll find are supportive if they're not immunosuppression. So the management is primarily centered around managing the edema and the volume overload. So giving a low sodium diet, restricting fluids, maybe even giving loop diuretics if needed. The next one is a Goodpasture syndrome, otherwise known as anti-glomerular basement membrane disease. So this is driven by autoantibodies against the basement membrane of both the alveoli in the lungs and the glomeruli in the kidneys. So this is a form of RPGN, which means it's typically going to have a very acute presentations, and it most classically causes hemoptysis, owed to the alveolar damage, and hematuria, owed to the glomerular damage. And it also is going to follow a recent exposure. There's going to be a specific trigger that's mentioned in the vignette. So either a house fire or in a cigarette smoker or secondhand smoke or certain chemicals or paints, so on and so forth. And labs will show RBCs and RBC casts. So for treatment, you give IV corticosteroids immediately, often with cyclophosphamide. So this is not a self-resolving condition. This is something that requires immediate attention. And for definitive treatment, if indicated, you will do emergent plasmapheresis. And this is going to be a unique treatment among GNs. You're not going to see emergent plasmapheresis done very often for other GNs. That's going to be mostly for Goodpasture syndrome. All right, so moving on. Next one is membranous nephropathy. So the pathophysiology behind this is immune complex deposition in the basement membrane. It's going to present with your classic nephrotic syndrome, so peripheral edema, leg swelling usually. And in labs, you're going to see almost exclusively proteinuria. You're probably not going to see hematuria. And if they do perform a urine microscopy, you will see a fatty cast or oval fatty bodies. So this is kind of like the classically like what we think of classic nephrotic syndrome. Some associations, it is associated with Hep B and cancer. So just keep that in mind. And treatment is supportive. It's usually self-limiting. Next one is a membranoproliferative GN or MPGN. It's very similar to membranous nephropathy, except it also involves the mesangium of the glomeruli. So it's not just nephrotic syndrome, it can also cause nephritic syndrome. So it has a bit more variability in its presentations, and it's associated with Hep C and Hep B viruses. Treatment is also supportive. Minimal change disease is idiopathic, and honestly, you probably don't really need to know the pathophysio that much. But it is usually cytokine mediated, if you're curious, as opposed to immune complex or antibody mediated. And its presentation, it's honestly, think of it, if you want, you can think of it as a membranous nephropathy in children. So you're going to see peripheral edema, nephrotic syndrome, and it's almost exclusively in kids. Sometimes you will see it in young adults, but almost always in kids, especially in test questions. And so labs, you're going to see isolated proteinuria and maybe fatty casts. Again, very similar to membranous nephropathy. The only main thing is that steroids have an excellent response. So minimal change disease, steroids is a very good treatment. For FSGS, similarly, the pathophysio is idiopathic. You don't really need to stress too much about it. It is cytokine mediated if you're curious. It is mostly a nephrotic syndrome, so it will present with leg swelling and proteinuria, maybe some hematuria on labs. It's associated with HIV, heroin, and obesity. So these are three kind of important associations to remember for FSGS. In fact, it's the most common nephrotic syndrome seen in HIV patients. So the treatment is supportive and treat the underlying condition. So if they are a heroin user, or if they have HIV, or if they're obese, treat those conditions because that is likely what's contributing to the FSGS itself. Do not give steroids, right? Unlike minimal change disease, FSGS does not have a good response to steroids. So just so you know. Next one is ANCA-associated vasculitis and glomerulonephritis. This one, I'm just going to admit with you guys, it's not going to be my most thorough work because it honestly could indicate like a whole like talk in and of itself. There's all these subtypes and everything like that. But generally speaking, just know that it's driven by autoantibodies against proteins within neutrophils. And it is a small vessel vasculitis, which means that common symptoms are going to be pneumonitis, rapidly progressive GN, palpable purpura, and so on. And if they give you labs, they might tell you that MPO or PR3 serology are positive, and these are just antibodies against specific neutrophil proteins. So some associations and fun facts. Keep in mind there are several subtypes of AAV. So, and those subtypes might present with additional symptoms in addition to these classic symptoms. So one example that they like to ask a lot is eosinophilic granulomatosis with polyangiitis, otherwise known as EGPA. And so in addition to glomerulonephritis or palpable purpura, these patients will also often have a history of asthma or a sinusitis. So just think eosinophil allergies, right? So kind of AAV symptoms in an allergy-prone patient. And treatment for this is immunosuppression. Next one is lupus nephritis. And this is driven by the hyperactive autoreactive lymphocytes seen in systemic lupus erythematosus. And the presentation, pretty straightforward. Just think of your classic lupus symptoms plus glomerulonephritis. So on labs, you might see either proteinuria or hematuria on the UA. You'll see SLE serology, so either anti-double-stranded DNA or lupus anticoagulant, so on and so forth, and maybe even see the lupus-associated labs like the cytopenias that commonly occur in SLE. And so for treatment, also pretty straightforward. Just treat it as if it was an acute lupus flare. And so where does your mind go for that? Immunosuppression. Give steroids, cyclophosphamide, and then the long-term management is going to be the lupus medications you're familiar with, like hydroxychloroquine. And our last one is mixed cryoglobulinemia. This is a process that's driven by cryoglobulins that clump together in the blood and tissues. And cryoglobulins, they are abnormal proteins, usually IgM or IgG, that precipitate out of the blood at low temperatures. So when they do that and they clump together in the blood and tissues, that can cause damage in the kidneys and so forth. So it commonly presents with a very wide array of various symptoms. Some of the common symptoms include fatigue, palpable purpura, arthralgias, and/or glomerulonephritis. But some additional symptoms might include a peripheral nephropathy or neuropathy, sorry, peripheral neuropathy, a hepatosplenomegaly, just non-specific systemic symptoms. This is honestly overall a very frustrating disease to try to diagnose in questions because it can be so vague and it just has a whole list of potential symptoms. But something that might help are the labs. So the labs are going to show decreased C4, which is an important one, and slightly less important, rheumatoid factor may or may not be positive. And some other labs might include elevated LFTs, like transaminitis, again, kind of linking back to the hepatosplenomegaly you might see in these patients. And some associations, there's two major viral infections that might be associated with mixed cryoglobulinemia, and that's HCV and HIV. So for treatment, you immunosuppress the patient and you treat the underlying cause. Pretty similar to some other GNs. So let's do some practice questions. So this first one, young adult female presenting with red blood cells and proteinuria on the urine analysis. She's also reporting symmetric, migratory, polyarticular arthralgias, especially in the knees and fingers, with brief morning stiffness. Exam shows painless oral ulcers and splenomegaly. What's the likely diagnosis? And you can pause the video if you need time to figure it out. The likely diagnosis here is a lupus nephritis. So what she has is this migratory arthritis especially in the knees and fingers. That's pretty big for lupus, with a brief morning stiffness. And then also mucosal or ulcers can be seen in lupus, as well as splenomegaly. And she's presenting with what seems to be an acute lupus flare with lupus nephritis. This next case is an asthmatic patient presenting with hematuria. The exam shows a palpable purpura and sinusitis. Which diagnosis or vasculitis is this most consistent with? So I kind of already gave a hint, but you can pause it if you need to think. The most likely diagnosis here is EGPA, and that's the subtype of ANCA-associated vasculitis that we were talking about earlier. That's associated with, again, the eosinophilic nature of it contributes to the sinusitis and asthmatic history. And then when you add that with the palpable purpura and the hematuria, it's most consistent with associated vasculitis. Thirdly, patient presents with arthralgias, fatigue, and painless palpable purpura on the bilateral legs. Laboratory exam reveals elevated LFTs, evidence of glomerulonephritis, so hematuria and proteinuria, and a low serum C4 was the most likely diagnosis. The most likely diagnosis here is a mixed cryoglobulinemia. So our main takeaways are the palpable purpura bilaterally, and the glomerulonephritis. Now you might ask, well, Brendan, like, sometimes IgA vasculitis and IgAN, they can also have hematuria and they can have palpable purpura. And we also just talked about ANCA-associated vasculitis that can have palpable purpura. So how do we distinguish that? There's a few takeaways. So for one, IgA nephropathy is almost always going to be only hematuria. If there is proteinuria, it's going to be very, very trace. So that's going to be maybe giving you like a slight edge. But really the main thing are the additional findings that you see in mixed cryoglobulinemia. So you're going to see potentially the transaminitis. You do not see elevated LFTs in ANCA-associated vasculitis or in IgA nephropathy. And then also the low serum C4. Remember at the beginning when we talked about it's very important. IgA nephropathy has normal C3, normal C4. So if you have a patient who seems like they might be a vasculitis, a picture with glomerulonephritis, if they have hypocomplementemia, then that tells you this is not IgA nephropathy. And that's because if you're curious, IgA antibodies, they adhere fairly poorly to complements, versus IgG and IgM, they adhere much more prominently. Okay, we have a few more practice questions. I won't spoil the source of these questions. Let's just say that just don't copyright strike me, like let's just say I found these online. But this is a 7-year-old boy brought to the office due to lethargy and dark urine. The patient has had no abdominal pain, fever, dysuria, urinary frequency or urgency. Temperature is 99.3 Fahrenheit. Physical exam shows periorbital swelling and mild pedal edema. Cardiopulmonary exam reveals no abnormalities. The remainder of the exam is unremarkable. Laboratory results are as follows. Serum C3 is low, C4 is normal. Which of the following is the most likely diagnosis? So I'll let you give you a second, pause it if you need to figure it out before revealing the answer. So the answer here is PSGN. And so some of the key highlights here, this is a pediatric population. So already, that's where you primarily see PSGN. He's coming in with dark, gross urine. He has some periorbital swelling, very mild pedal edema, so nephritic syndrome. And then on urine analysis, we see a lot of blood and some white blood cells. You see red blood cell CAS, and then ding, ding, ding right here is the low C3, but the normal C4. That's most consistent with PSGN. And yeah, we ruled out IgA nephropathy because of low C3. Also, the age demographic is more consistent with PSGN, but not definitive. Yep. All right, so if you're ready, on to the next question. A 25-year-old man comes to the emergency department with shortness of breath and cough productive of a blood-tinged sputum for the past few days. He's not had any fevers, arthralgias, or weight loss. He's never had these symptoms before and is extremely concerned. The patient has no history of recent travel or sick contacts. He smokes half a pack of cigarettes daily, and he has had two sexual partners in the past 6 months. Temperature is 98.9 Fahrenheit. Blood pressure is 120 over 70. Pulse is 102. Respirations are 22. Lung auscultation reveals patchy bilateral rales. Chest X-ray demonstrates bilateral pulmonary infiltrates. Serum creatinine 2.6. UA shows dysmorphic red blood cells, which defines most likely cause of this current condition. So I'll give you a second to think about this. So the answer for this is anti-glomerular basement membrane disease, otherwise known as Goodpasture syndrome. Some of the highlights I brought up here: blood tinged sputum. So hemoptysis plus hematuria should make you either think of Goodpasture syndrome or make you think of ANCA-associated vasculitis. Those are the two main things. Hasn't had any fevers, weight loss, arthralgias, no travel or sick contacts, cigarettes daily. So cigarette smoker. That carbon monoxide exposure and all the chemicals that are in cigarettes that can cause a Goodpasture syndrome. All right. A 35-year-old man comes to the office due to progressively worsening lower extremity edema. He has exertional dyspnea, but no orthopnea. Temperature is 98.8 Fahrenheit. Blood pressure is 145 over 92. Pulse is 80. Respirations are 14. BMI is 52. Cardiac exam shows normal rhythm and no murmurs or gallops. The lungs are clear to auscultation. There's no jugular venous distension. The abdomen is large and soft. There's 2 plus pitting edema in both feet. Serum creatinine is 1.7. UA shows 4 plus protein, but is otherwise normal. A 24-hour urine test shows protein excretion of 5 grams. Kidney biopsy is obtained. 10% of the examined glomeruli have global sclerosis, and another 10% have partial sclerosis in the perihilar region. Non-sclerotic glomeruli exhibit slight enlargement without significant proliferative changes. Immunofluorescence study shows no deposition of immunoreactants. Electron microscopy shows 40% food process effacement. HIV testing is negative, which defines most likely to slow progression of patient's renal dysfunction. This is a tough one, so take extra time if you need to pause the video and try figure it out before I move on to the answer. So the answer here is E, weight loss. So the diagnosis that we were supposed to be thinking of here is FSGS. And I know I told you like I wasn't going to talk about electron microscopy or immunofluorescence, so I'm sorry, but you will be able to answer. You would have been able to answer this question even without that. And the main things here are the nephrotic syndrome, the obesity, and the sclerosis. So some of the glomeruli, sorry, have global sclerosis. Some have partial sclerosis, and then some don't have any sclerosis. So that's textbook FSGS, by name, focal segmental glomerular sclerosis. His HIV testing is negative. Why do you think we would get HIV testing? Again, because that's one of the associations with FSGS. So we know that he's not HIV positive. So given that he has obesity and he's HIV negative, there's no mention of heroin use here. It's safe to say that his obesity, let's assume that the obesity is the primary association with the FSGS in this case. And so the management of FSGS is supportive in treating the underlying cause. And if the underlying cause is a high BMI, then the appropriate management will be weight loss. So again, this is a difficult question. It's not super high yield, so don't worry if you got it wrong. But yeah, just to summarize here, yeah, there's association between FSGS and obesity. So if you see FSGS in an obese patient, treat the underlying cause. And I believe that, yes, that is the last question we have today. Let me know how I did. Leave a comment below asking what you think I did well, what you would like me to focus on more. Was this helpful? Was the structure helpful? Please, I'm open to any and all feedback. So thank you so much for watching. Thank you for your time, and I'll see you guys next time.